Good morning, good afternoon, good evening, everyone, wherever you may be watching us in today's video. We will continue with a walkthrough of Netter's anatomy flashcards, continuing now with the different muscles of facial expression. Seen here on lateral view, you can follow the cursor along as we look at the different labeled components. Number 1 here, superior to the ear, is the auricularis superior muscle. The auricularis superior muscle. Anterior to the ear, we have the auricularis anterior muscle. Superiorly overlying the scalp is the epicranial aponeurosis. Anteriorly, we have this small muscle here, which is the corrugator supercilii muscle. The corrugator supercilii muscle. And anterior to it is the procerus muscle. Number 6 here is the nasalis muscle. And posteriorly, we see the zygomaticus minor muscle anteriorly, the zygomaticus minor muscle, and behind it, the larger muscle strip is the zygomaticus major. Overlying the chin area, we have the mentalis muscle, and posterior to it is the depressor labii inferioris, Posterior to the orbicularis oris muscle, just this circular muscle over here, posterior to it is the risorius. Key takeaways here are that number 1, all muscles of facial expression are innervated by terminal branches of the facial nerve, which is cranial nerve number 7. Number 2, these cutaneous muscles all lie within the layers of the superficial fascia. Finally, all of the muscles of facial expression are derived embryologically from the second pharyngeal branchial arch, and again are innervated by the facial nerve. We now go into a detailed look at the eye. Here is a right lateral view, and we focus on this muscle strip over here, which is the levator palpebrae superioris. Origin, it arises from the lesser wing of the sphenoid bone, and it is anterior and superior to the optic canal. It attaches to the skin and the tarsal plate of the upper eyelid. The levator palpebrae superioris acts to raise the upper eyelid. It is innervated by the oculomotor nerve, which is cranial nerve 3. At the distal end of this muscle, near its attachment to the tarsal plate, is a small amount of smooth muscle called the superior tarsal muscle. The fibers are supplied by postganglionic sympathetic fibers of the autonomic nervous system. Because of the dual nature of the levator palpebrae superioris, it is skeletal and has a small smooth muscle component. Drooping of the upper eyelid can result from a nerve lesion affecting either the oculomotor nerve or the sympathetic fibers, or both. This drooping is called ptosis. Damage anywhere along the sympathetic pathway from the upper thoracic sympathetic outflow to the head, the cervical sympathetic trunk, or the superior cervical ganglion and beyond can result in denervation of the small tarsal muscle, the smooth muscle that is found at the free distal edge of the levator palpebrae superioris. This will result in a mild ptosis wherein the ipsilateral upper eyelid droops, but only slightly. So again, to recall, the levator palpebrae superioris is primarily skeletal muscle, but a small distal tip is actually smooth muscle. A closer look at the different extrinsic eye muscles. Let us look at the different labeled parts here. One is the superior rectus muscle on top of the eyeball, superior rectus muscle. Number 2, medial to the eye, of course, is the medial rectus muscle. Number 3, inferior to the eyeball is the inferior rectus muscle. And number 6 here is the inferior oblique muscle. The inferior oblique. A superior view reveals the superior oblique muscle over here. Number 3, we see again the inferior rectus, which is below or inferior to the eyeball in this orientation. And number 5 here, lateral to the eyeball, is the lateral rectus. The lateral rectus is actually this cut muscle over here, the lateral rectus. The origin, the 4 rectus muscles and the superior oblique arise from a common tendinous ring, which is the annulus of Zinn. The annulus of Zinn, which is on the body of the sphenoidal bone. The inferior oblique, on the other hand, arises from the floor of the orbit. The 4 rectus muscles insert into the sclera, which is the white of the eye, over here, just posterior to the cornea. The superior oblique muscle passes forward and its tendon passes through a fibrous ring or a trochlea and inserts into the sclera deep to the superior rectus muscle. The inferior oblique muscle inserts into the sclera deep to the lateral rectus muscle. In clinical testing, when the eye is abducted, the superior rectus will elevate the globe and the inferior rectus depresses it. When the eye is adducted, the superior oblique depresses the globe and the inferior oblique elevates it. The medial rectus is a pure adductor, whereas the lateral rectus is a pure abductor. The anatomic actions differ from the actions tested for clinical evaluation of the muscles. The lateral rectus is innervated by the abducens nerve or cranial nerve 6. The superior oblique over here is innervated by the trochlear nerve. So we have SO4 and LR6. And the other rectus muscles, as well as the inferior oblique, are innervated by the oculomotor nerve. So that's superior oblique, cranial nerve 4, lateral rectus, cranial nerve 6, and the rest of the other muscles, cranial nerve 3, which is the oculomotor nerve. Ipsilateral trochlear nerve palsy will result in the patient's inability to fully abduct the ipsilateral eye. Ipsilateral trochlear nerve palsy will result in the patient's inability to adduct and depress the ipsilateral eye, resulting in diplopia or double vision. Third nerve palsy will result in ptosis, a dilated pupil, and an inability to adduct the eye at rest. The affected eye will be directed down and out. We go now to the different muscles involved with mastication, starting with this huge fan-shaped muscle over here, the temporalis muscle. The origin of the temporalis is the floor of the temporal fossa, and the deep surface of the temporalis fascia, and it inserts to the tip and the medial surface of the coronoid process and anterior border of the ramus of the mandible over here. The temporalis acts to elevate the mandible and closes the jaws. Its posterior fibers retract the mandible. That is, it causes the mandible to perform retrusion. The temporalis is innervated by the mandibular division of the trigeminal nerve. The temporalis is one out of the 4 muscles of mastication. It is a broad radiating muscle whose contractions can be seen during chewing. The muscles of mastication are derived embryologically from the first pharyngeal branchial arch and are innervated by the mandibular division of the trigeminal nerve, which is cranial nerve 5-3. Our second muscle of mastication, the masseter, over here. The masseter arises from the inferior border and medial surface of the zygomatic arch, and it inserts into the lateral surface of the mandible and the lateral surface of the coronoid process. It closes the jaws by elevating the mandible. And as with the other muscles of mastication, it is innervated by the mandibular division of the trigeminal nerve. The muscles of mastication again are all derived embryologically from the first pharyngeal branchial arch. Our third muscle of mastication, the medial pterygoid, seen here better in posterior view. The medial pterygoid. This muscle arises from 2 slips. Its deep head arises from the medial surface of the lateral pterygoid plate and pyramidal process of the palatine bone, and its superficial head arises from the tuberosity of the maxilla. The medial pterygoid inserts into the medial surface of the ramus of the mandible, inferior to the mandibular foramen. The medial pterygoid helps to close the jaws by elevating the mandible. With the lateral pterygoids, the 2 medial pterygoids protrude the mandible. When one medial and one lateral pterygoid on the same side of the head act together, the mandible is protruded forward and to the opposite side. Alternating these movements moves the jaws from side to side in a grinding motion. As with the rest of the other muscles of mastication, it is innervated by the mandibular division of the trigeminal nerve. Finally, our fourth and final muscle of mastication, the lateral pterygoid. So to review, we have the 4 muscles of mastication, the temporalis, the masseter, the lateral pterygoid, and the medial pterygoid. The lateral pterygoid over here, seen on lateral view, arises from the superior head in the infratemporal surface and the infratemporal crest of the greater wing of the sphenoid bone, whereas the inferior head arises from the lateral surface of the lateral pterygoid plate. It inserts by converging into the neck of the mandible, articular disc, and capsule of the temporomandibular joint over here. The lateral pterygoid opens the mouth by drawing the condyle of the mandible and articular disc of the TMJ forward. With the medial pterygoid of the same side, the lateral pterygoid protrudes the mandible. The jaw is rotated to the opposite side, producing a grinding movement. As with the other muscles of mastication, the lateral pterygoid is innervated by the mandibular division of the trigeminal nerve. And it is important to note that while the other three muscles of mastication help to close the jaws, it is the lateral pterygoid which opens it. So, a distinctive feature of the lateral pterygoid is that it helps open up the jaws. At the beginning of this action, it is also assisted by the mylohyoid, the digastric, and the geniohyoid muscles. We now move into the floor of the mouth. In this antero-inferior view, we can see clearly the mylohyoid muscle. Origin, the mylohyoid arises from the mylohyoid line of the mandible, and it inserts into a median fibrous raphe and the body of the hyoid bone over here, posteriorly. The mylohyoid elevates the hyoid bone over here and raises the floor of the mouth during swallowing, pushing the tongue upward as in swallowing or protrusion of the tongue. It is innervated by the mylohyoid nerve, which is a branch of the mandibular division of the trigeminal. The mylohyoids also can help depress the mandible or open the mouth, and they are active in mastication, swallowing, sucking, and blowing. The mylohyoid, together with the geniohyoid muscles, form the floor of the mouth. And speaking of the geniohyoid muscles, over here, their origin is the inferior mental spine of the mandible, over here, and they insert into the body of the hyoid bone. They slightly elevate and draw the hyoid bone forward, shortening the floor of the mouth. When the hyoid bone remains fixed, this muscle also helps retract and depress the mandible. A useful tip when determining the origin and insertion is to look at the name of the muscle. For example, genio stands for the mandible. So we know that this muscle has its origin from the mandible, and hyoid, of course, refers to the hyoid bone, wherein we know that therefore the geniohyoid muscle, while having its origin from the mandible, inserts into the hyoid bone. Same is true for the mylohyoid muscle, wherein we recall that the mylohyoid arises from the mylohyoid line, and it inserts again into the hyoid bone. The geniohyoid muscle is innervated by C1 via the hypoglossal nerve, which is cranial nerve 12. The digastric, the stylohyoid, the mylohyoid, and the geniohyoid muscles are all considered as suprahyoid muscles because they lie above the hyoid bone. So again, we have four suprahyoid muscles: the digastric, the stylohyoid, the mylohyoid, and the geniohyoid. We now move closer into the tongue itself, starting inferiorly with the genioglossus muscle, seen here on cut lateral view. The genioglossus arises from the superior part of the mental spine of the mandible, over here, and the genioglossus inserts into the dorsum, or the posterior aspect of the tongue, and the body of the hyoid bone. The genioglossus acts to depress the tongue, and its posterior fibers protrude the tongue, as in sticking the tongue out of the mouth. It is innervated by the hypoglossal nerve, and the genioglossus is actually one of three extrinsic muscles of the tongue. These extrinsic muscles move the tongue, whereas the intrinsic muscles change the tongue's shape. All of the muscles with glossus in their names are innervated by the hypoglossal nerve, except for one, the palatoglossus, because the palatoglossus muscle is a muscle of both the tongue and the soft palate, and it is innervated by the vagus nerve. So all muscles with the word glossus are innervated by cranial nerve 12, except for the palatoglossus, which is innervated by cranial nerve 10 or the vagus nerve. Moving posteriorly still is the hyoglossus. Its origin arises from the body and greater horn of the hyoid bone over here, and it inserts to the lateral and the dorsal surface of the tongue. It depresses or pulls the tongue into the floor of the mouth while also retracting the tongue. And again, glossus being in its name, it is innervated by the hypoglossal nerve. Our clinical correlation here, the lingual artery, a branch of the external carotid artery, is the major blood supply to this area, and it can be located as it passes deep to the hypoglossus muscle. Bleeding that results from soft tissue damage in this region causes swelling as the blood accumulates in the floor of the mouth. Posteriorly, we can see here the styloglossus muscle, Judging from the name, its origin is from the styloid process and the stylohyoid ligament, whereas its insertion is into the lateral side of the tongue. And some fibers also interdigitate with fibers of the hyoglossus, which is over here. The styloglossus retracts the tongue and draws it up during swallowing. The styloglossus is again innervated by the hypoglossal nerve. Of course, our only exception to the hypoglossal innervation is the palatoglossus, which is innervated by cranial nerve 10, which is the vagus nerve. It is important in swallowing because it pushes the bolus of chewed food up against the hard palate and backward into the oropharynx. Moving superiorly into the roof of the mouth, we can see here posteriorly the levator veli palatini muscle. The levator veli palatini arises from the cartilage of the auditory tube and the petrous portion of the temporal bone. It attaches into the palatine aponeurosis of the soft palate. The LVP, the levator veli palatini, elevates the soft palate during swallowing and yawning, and it is innervated by cranial nerve 10, the vagus nerve. After the soft palate has been tensed by the tensor veli muscle, which hooks around the pterygoid hamulus, the levator elevates the palate. Speaking of the tensor veli palatini, it is the muscle which is more medial. It arises from the scaphoid fossa of the medial pterygoid plate, the spine of the sphenoidal bone, and the cartilage of the auditory tube. And it inserts into the palatine aponeurosis of the soft palate, just like the levator veli palatini. The TVP tenses the soft palate, as the name implies, and by contracting, opens the auditory tube during swallowing and yawning to equalize pressure in the middle ear. So it opens up the auditory tube, also known as the Eustachian tube. This is an anterior view of the roof of the mouth. Looking now at the labeled components, number 1 is the uvular muscle. Number 2, lateral to it, is the palatopharyngeus muscle. Palatopharyngeus muscle. Palatopharyngeus, of course, having its origin from the soft palate and its insertion into the pharynx. Number 3, we have the palatoglossus muscle, its origin being the soft palate and its insertion into the tongue, the palatoglossus. More lateral, we have the superior pharyngeal constrictor muscle. Number 5 here is the pterygomandibular raphe in white, the pterygomandibular raphe. And number 6, more superficially and laterally, is the vaccinator. Interdigitating fibers of the levator veli palatini muscle make up most of the soft palate. So most of the soft palate is because of the levator veli palatini, along with the little uvular muscle over here. The palatoglossal and the palatopharyngeal arches contain small slips of muscle beneath their mucosal surfaces. These thin muscle slips are innervated by the vagus nerve. The palatine tonsil is nestled in the palatine fossa, which is between these two muscles. The vaccinator muscle lies deep to the oral mucosa of the cheek and helps keep food between the molars. This muscle of facial expression is innervated by the facial nerve. Numerous minor salivary glands populate the mucosa lining the hard palate. Our takeaway here, the palatine tonsils are between the palatoglossal and the palatopharyngeal arches. We shall continue with the rest of the head and neck structures in our next video. Thank you very much for watching and have a good day.